So thank you again for joining us. I know we just had another meeting on Friday about the Create Equity thing, but this is going to be a great four-part capacity building training series over the next 4 months. And we have a special guest trainer, Michael Hager. He is a subject matter expert and does CQM training for cities, states, and territories across the country. And he has a team that helps him with his work. So he'll be, or we have Jasmine Black also joining us. So I will let them introduce themselves. Y'all know me already. I'm Julie Saber, the quality coordinator for HIV care services at the Department of State Health Services in Texas. So thank you so much for joining us on a Monday morning.
Thanks so much, Julie. And I'm Michael Hager. I'm the president and CEO of Hager Health. And as Julie mentioned, I work with states, cities, and health care providers across the country on RWHAP HIV/AIDS program CQM. And I've assembled a team, Jasmine Black and Jamie Shank, who will be switch hitting across our 4-session series. So today we have Jasmine with us. And Jasmine, introduce yourself for us.
Yeah, hi. So I'm Jasmine Black, the founder and CEO of Black Health Consultancy, largely focused on quality management consultancy and consulting within public health spaces to address equity and anti-racism practices. So I do a lot of work with Michael in my regular job life, and then also now in the consulting field. So I'm happy to be here.
Great. And we're just managing the room as far as our folks who are entering, just kind of looking at the waiting room. And we have 26 people online now, and we still have some folks trickling in. So if there's any pauses, it's because we're looking at the waiting room and making sure that we're accepting people into the room and all of that. Go ahead and share my slides. Can you see those slides? All right, great. So for today's session, let me advance to the next slide. Today's session really is focusing on an introduction for CQM for all of you. Now, I know that some of you will have already had these types of trainings before. So there may be a little bit of a repeat, but for some of you, it'll be new as well. So Jasmine and I are going to be walking through today's session. There'll be polling and lots of opportunities for you to discuss your own experiences and also raise your questions and concerns as it relates to CQM and the work that you're doing in Texas. All right. So I think that most of you are accustomed to using Zoom, but just a couple of helpful hints. It should be opened in full screen mode right now, but you can hit escape to exit full screen mode. You can hover over the top or the bottom of your screen, wherever you have your little toolbar, and it has a microphone, a video. You can mute yourself. You can stop your video there as well. We recommend that you leave yourself on mute until you're ready to pose a question or make a comment, because you know, there can be background noise and other situations as well. We do ask that you leave your camera on when we're having discussions and when the slides are taken down, so that we're able to see each other and really interact. But we do know that bandwidth can be an issue. So if you have kids in your household learning with you, or other folks who are working from home, and you're getting a little message at the bottom of the screen saying that your connection is unstable, just go ahead and turn off your video. That oftentimes will help. So we understand that not everyone's going to be able to have their video on the whole time, but we do again want you to try to have your video on during the discussion so we can see each other. And we are recording these meetings so that we're able to save them and share them for future training, and also for anyone who misses today's training. The last thing that we're looking forward to is if you're able to put your name in the chat room. That just kind of helps us out. A couple folks who are on just the phone, you're able to mute and unmute by pressing #6 and *6. We'll hopefully be able to find out who you are through conversation as we work our way through the meeting. So some learning objectives for today's meeting. This really is an introduction. So we want to make sure that you understand the groundwork and the foundation for federal expectations and guidance for clinical quality management in the Ryan-White HIV/AIDS program. We want you to list the 3 components of CQM in the ball and pedestal model that we're going to be covering. We want you to describe the nuance between CQM and administrative funding. We want you to discuss opportunities for administrative agencies to exercise leadership in regional CQM activities across Texas. Now, this is just an introduction. We're going to be getting much deeper into this with you in future sessions, but we do want you to talk at least about those high-level opportunities from today's conversation. And then finally, explain the difference between quality assurance and quality improvement activities, which is, you know, a really important distinction in our field. Now we have 2 hours for today's session, including polls and discussion. This actually is quite a tall order, but I know that we're going to be able to make it through. All right. So we're going to open up with a poll. And so let me launch our opening questions, and I'm going to turn it over to Jasmine to walk us through.
Yeah, absolutely. So your poll should have popped up on your screen. Our first question that we have here is, have you been trained on CQM or clinical quality management in the Ryan-White HIV/AIDS program previously? I see we already have 3 respondents in. Our second question is, what is your level of comfort around the Ryan-White HIV/AIDS program CQM subject matter? And it looks like we're at 32% of polls already answered. 42%. We're seeing a lot of people have had some previous training. And most people are somewhat or not comfortable.
Great. That's why we're here, right?
Right, exactly. 73%, 76% of the polls in.
Let's see if we can catch another 2 or 3.
Yeah. Almost. Anybody else? 82% in.
All right, let's share this with you so you can see what we're seeing.
Yeah, so it looks like a couple or majority of you, 45%, have been trained at least once or twice and are self-proclaimed novice in the CQM program. And then majority of people are somewhat comfortable or not comfortable, which is okay, because we're going to be working with you all over the next couple of months to receive some training. Hopefully, you'll see an improvement in your understanding and your comfortability as we move forward.
Yeah. And so I think the other thing, just to reemphasize, is that we have all kinds of folks here who have all kinds of backgrounds. So we want this to be valuable for everyone. So as you are listening to us talk, if you have something that you think is, you know, needs more attention, raise your hand or shout out or put the question in the chat room. Or if you think that the content that we're providing is very basic and you have a more advanced question, don't be shy to ask that either. We're going to teach in both directions here. So make sure that, you know, you are ready to ask your questions, and because we're ready to answer them for you. All right.
Okay, so we're going to get started with some introduction to CQM here. The next slide for me, Michael.
Mm-hmm.
So in Texas, you all have a sort of additional administrative layer that involves the majority of you who are here on the call as administrative agencies. So traditionally in the Ryan-White HIV/AIDS program, we usually refer to HRSA as our funders. So that's our HRSA for any of those who are not familiar with our acronyms. And then the Texas Department of State Health and Services for you all operates as your recipient of Part B funds, which are then passed through to direct service providers by you all as administrative agencies. So this means that while you are subrecipients of funds technically, the real action that we're interested in for your CQM work really happens at your provider level. So essentially they're like subrecipients in this Texas model. So in this model,
Oops, sorry.
It's okay. In this model, it's important to note that the AAs are fully responsible for the providers that are funded in your region. And throughout this presentation, please feel free to ask questions if there's confusion about like any level that we're discussing on each slide. Next slide, Michael. So the HRSA HAB or HIV/AIDS Bureau Policy Clarification Notice 1502 is one of the specific regulations that Ryan White recipients must adhere to in relation to quality management. So it really governs the CQM program for Ryan White recipients for every Ryan White part of funding and for their subrecipients, or in this case, also your subrecipients across all parts. So focus really rests largely on improving HIV health outcomes for clinical quality management based on PCN 1502. Next slide. So looking at the components of the CQM program, the program does coordinate activities and aim at improving patient care and patient satisfaction to drive health outcomes. There's three components of a CQM program. So you see at the base here that we have infrastructure operating within the marble, then right above the base are a continuous cycle of performance measurement and quality improvement. So CQM activities are always continuous, they're not periodic, and they do fit within the framework and support grant administrative functions, but costs are separate from grant administrative functions. And we will talk more later about the differences between admin and CQM. So diving in deeper to this pedestal, you can see that you can't do quality management without reliable performance measure data to guide all of your efforts. I think you have another picture that's going to pop up here, Michael. There we go. So they're the yin to the yang, they all fit together. What does it say on the slide, Michael? Miss you too. And so it is essential to have very reliable performance measurement data in order to guide all of your improvement work. We're going to talk through some of that data here. Next slide, Michael. Looking at grant admin functions, grant administration does not improve health outcomes. So it is not clinical quality management. The hair is split along the lines of a focus on improving HIV outcomes. So you can see here, grant administration does not equal clinical quality management. In fact, grant administration is the bare bones operation of the work that you all do. It is what's mandated in all of the work within your contracts and all of those things, whereas clinical quality management operates as a separate entity in addition to your grant administration functions. And it does, again, aim to support all of the grant admin functions. You have anything to add to that, Michael?
No, I just think that, you know, we can't emphasize enough that how that hair is split. And I think that, you know, you'll see over and over and over again, the most important distinction is HIV health outcomes, endpoint HIV health outcomes. So, you know, if you keep asking yourself that question, that will help you to be able to make that separation.
Yeah, and then the next slide will help a little too. So here on this slide, we have some examples with splitting the hair between grant admin and clinical quality management. So as you can see, grant administration is focused on fulfilling the contractual requirements for a grant with HRSA and HAB, where clinical quality management either adds on or creates something new that's purely focused on improving HIV health outcomes. So within grant administration, you could create a performance measurement system to collect minimum data where that's required of Ryan White HIV/AIDS programs legislation and of the HIV/AIDS Bureau. But within quality management, clinical quality management, you could create a sophisticated performance measurement system that collects service data that's tied to HIV health outcomes. So what do we fund, and are we collecting that data, which is a typical grant admin function, but how is that data then linked to the improvement of health outcomes for people living with HIV within your region? Looking further at this slide, you could also create care systems and service standards, which is a grant function that is mandatory and legislatively required by HRSA. But within clinical quality management, you would work to have tests of change to improve care and systems or your standards that were then created. A management of mandated reporting is something that would operate within your grant administrative side of your program, while a management of a peer learning or collaborative program may be a clinical quality management function. Provider training geared towards compliance would be grant admin, while provider training geared towards improving health outcomes or utilizing evidence-based or evidence-informed programming may be a part of your clinical quality management program.
To me, this is a really important thing to lay on, because I think that on the left side, it's about checking a box, right? Like you're required to have these things. Do you have something? You know, you've checked the box, that's administration. But anything that goes beyond that general checking of the box, that is about system enhancement, you know, really furthering health outcomes. That word sophisticated up at the top right, you know, creating a sophisticated performance measurement system, that would be something like identifying disparities, helping us to concretely find those opportunities for improvement, not just spitting out numbers, but thinking about where we can act, right? So that is an example of how we take something that is a basic grant expectation and transform it into something that really is helping us to systematize improvement.
Thank you so much, Jasmine and Michael. I think this is really important. This information comes up a lot. We get so many questions about this, and there's such a gray area, right? So
Yes.
thanks for bringing this up at the very beginning. Does anyone have questions or thoughts about this? No? Okay.
This is really one of the toughest hairs to split. And once you can do that, then you'll start to see this elevation within your quality management work that you're doing. You'll have this new layer of work that really enhances all of the things that you were doing. And then ultimately you can see that improved health outcome within your community. But it is the hardest hair to split, for sure. In Indiana, which is where I live, this was a really tough thing for people at the state level where I was working to grasp, and then all of our subrecipients to really understand at first. This was hard because you've been doing the grant administrative function for years.
I think one of the things that makes it really hard is understanding that there's the words that we use versus the intent. And this is a case where we might intend one thing, but our words are so important. The words used matter here. And the words that we use help us to distinguish what is the difference between grant administration versus clinical quality management. One thing to think about, and we'll, you know, we're going to emphasize this theme as we go in terms of leadership. We know what it feels like when we use the wrong words in customer service or in trying to work with supervisors, and we get turned down, right? Like, no, go away, go back, you used the wrong words. That's frustrating, right? So I think one of the ways that we can use, you know, this presentation and this learning to help exercise leadership across the state is to help people understand, to really focus with people in the field on what is the difference between these two. And that instead of just bouncing back people who use the wrong words, say, hey, you said this, but I think you meant this, because we need to distinguish between grant administration and quality management. So can you help me distinguish between the two? And that is a great example of ways that you can use this learning to help, you know, guide conversations and to guide work in the field.
So as the Part B recipient, infrastructure is the grounding element of a clinical quality management program. The elements included here are the keys to successes for any CQM infrastructure, but are expected to vary in scope across recipients. Subrecipients have more flexibility in implementing CQM programs under the guidance of their recipients, and we'll cover that too. So Leadership involvement is critical to the success of any quality management program, as Michael stated earlier, because without involvement of senior leadership in your quality management program, it can become misaligned from overall agency strategic planning and direction. Senior leadership doesn't need to be involved in day-to-day details, but more to help clear any sort of ideas around human and financial resources and how those are allocated, and to steer and align the program overall with our overall goals and objectives as a state or as a region. The quality management plan is really where infrastructure is written down and saved. It should include a description of all of these areas, but also the performance measurement system, the quality goals, and the quality improvement methods. The plan should be updated in an annual or a semi-annual cycle to reflect changes in infrastructure and shifts in performance measurement systems, and to name unique quality projects. The timeframe for the plan should be frequent enough that you assess the fit or the propriety of your quality goals, and that the work plan and evaluations are not overly drawn out. So 4 or 5 years is too long. In Indiana, we practiced our plans to be within a year. So every year we would have updates to those plans. And that was largely because we were really just getting in and digging our heels into doing the work. And so within that year, within the first few years, you really want to get a handle of things. And so waiting too long to look at it doesn't really help you refocus and readjust where, or realign where need be. And I would recommend that for any program that's really just getting started. For a program that's maybe more long-standing, maybe you're only really editing that plan and making larger changes every couple of years. Michael, would you say that's right?
Yeah.
Yeah, so I think a lot of states are moving to like 24-month plans, and
Yeah.
But after you've really had that established work done.
I think that an important thing to emphasize here is that, when we say recipient, we mean Texas dishes. And when we say subrecipients, we do mean you as administrative agencies, but traditionally that is viewed as the people in the field, the subrecipients. And so what we're trying to do here as administrative agencies is to bridge this gap, which is a little tricky. It's a little special that what you have in Texas to bridge this gap. And so I think it's all about taking the emphasis that is provided by our leaders in dishes, and then creating regional opportunities, regional programs. It's easy for our Part A's, right? Because they have literally an established region. It's a little trickier for those of us that aren't part of a Part A, because we have to create that network gel ourselves.
So your quality management committee has been constructed, or it can be constructed in different ways. Some states have small groups, while others have larger groups. For you all, it's a little special again because you function within the recipient, the subrecipient, and the sub-subrecipients. And so you'll have to make distinguishes on who will have what groups, and how would those things maybe blend into one another in their operations. Some states have small internal groups that are formed by larger external stakeholder groups, while other states allow subrecipients or sub-subrecipients in your case, and consumers to sit right on their actual committees. It is recommended that these groups meet at least quarterly to maintain focus and momentum, and also to review data that you all would be receiving around your performance measures. The important last component of your infrastructure is evaluation. So evaluation of a clinical quality management program is a simple model based on performance measurement data and quality activities, and testing the extent to which improvement goals are reached. The evaluation is used to inform the creation of the following cycles plan. For subrecipients or sub-subrecipients, and I think in your case, there's much more flexibility in terms of of a CQM program. So if subrecipients or sub-subrecipients are direct recipients of Ryan White funding of other parts, they will have different expectations set by HRSA. In creating an overall CQM program for your network, it is important to allow for certain flexibility that won't burden multiply funded agencies. We had similar issues here in Indiana for agencies within our TGA because we only have one that were multiply funded by parts A, B, and maybe C. And so it is a lot of balls in the air to juggle. So the more that you can be flexible with the work that they do and really try to find ways to be meaningful to involve across parts, the little bit easier it is to really set goals and reach them. Recipients recipients are expected to ensure that subrecipients or sub-subrecipients have the capacity to participate in network-wide CQM programs. So this can include CQM knowledge assessments, training delivery, creation of a place to enter performance measurement data for central analysis, creation of a place for recipients to securely share information. And this is not monitoring and evaluation. So again, really splitting those hairs of CQM work and grant administration work, which would include monitoring and evaluation. A formal CQM program is required, but the recipients should not spend all of their time reviewing CQM plans. Instead, CQM plans can be a requirement in contracts, and then whether or not they have a plan becomes a matter of compliance. So recipient CQM staff should spend their time coaching, training, providing technical assistance and other support to subrecipients through the lens of a network-wide CQM program. Expectations for subrecipients are enshrined within your RFA language, your contract language, statewide CQM plans. Subrecipient compliance with CQM expectations are monitored sort of indirectly through monthly reports, possibly, or directly through participation in citywide or regional-wide QM activities and through site visits and monitoring process. Next slide. So looking at performance measurement, measures should be selected that best assess the funded services through the lens of HIV health outcomes. So at a recipient level, recipients are strongly encouraged to include HRSA-HAB core measures. This will allow for better benchmarking and comparison across states and with recipients of different parts funded within the state. You're not required to use HAB measures, but the value of comparison and benchmarking cannot be understated. Subrecipients report on measures that are selected by the recipient. So this recipient really sets the tone on those measures, and then subrecipients report back on those. In Indiana, in practice, we also encouraged agencies to select additional measures within the work that they did, because some data is not data that we all at a state level can aggregate, but at an agency level, you may be able to view and identify opportunities for improvement. So essentially a provider level. And so that became really important in a lot of the work that they do. And overall, then you could see shifts and an improvement within the measures that were selected by the state based on the ins and outs of the works that providers would do for improvement.
Right. I feel like the Part A's also have the opportunity, those of you administrative agencies that are also Part A's have the opportunity to kind of like, again, take that network gel that you have by the virtue of being a Part A and kind of add additional measures to what Texas has selected. And, you know, of course, we should encourage people in the field that are providing services directly to capture whatever data they think is going to end up helping them to have the best picture of quality and the quality of the services that they provide to their patients, so that we can move forward.
Yeah. And it's also, you know, performance measures can really be informed by those quality committees that you create. So people who are in the field at a recipient level, or I mean, at subrecipient level or a subrecipient level, will really help inform those measures, and what may be helpful and what may just really not be helpful to them in the field. And that's where your committee becomes very important. Next slide. There we go. So how many measures should you have? The Ryan White HIV/AIDS program funded service categories were more than 50% of EMA supported consumers.
Sorry,
Yeah, I was like,
mistake.
It's okay. State supported consumers received at least one service unit, means that you need 2 performance measures. So in other words, highly utilized funded service categories have 2, right? If there's greater than 50% of all consumers that are supported by the Ryan White HIV/AIDS program funding receive at least one service element in that category, then you need 2. And this is new as of 2019? 2018, yeah, when they made the performance measures. Moderately utilized Ryan White HIV/AIDS program funded service categories just need 1 measure. So anything from about 15 to 50% or 49% of utilization needs 1 performance measure. For anything less than 15% of state supported consumers, you don't need a performance measure. You're not required to have a performance measure any longer by the Ryan White HIV/AIDS program. Consider the service to make the determination of what type of measure should be used. So viral load suppression may be appropriate for case management, but maybe it's not as appropriate for transportation or another funded service. Consider using maybe a patient satisfaction survey instead. So there's a lot of different ways you can do performance measures. And in Indiana, sometimes we had to get creative in those measures in order to really identify if what we were funding was really making a difference in health outcomes for the people that we were caring for in the community. Because ultimately, that is the goal of your CQM program.
Yeah. We do have some experience within our set of administrative agencies here looking at this concretely. We're working closely with the Dallas Administrative Agency. And so Dallas has been going through a series of work groups to identify what types of measure are the best measures to have for our various services that we provide, so that we can involve our subrecipients in a conversation about what it is that they are doing in the field and how that lends itself to the full continuum of care for people living with HIV. And then based on those conversations, you can have a determination. Do we want to focus on something that's more quantitative, like a clinical measure, or do we want to focus on something that's more qualitative, like an experience measure?
Next slide. So performance measures should be collected quarterly at a minimum, but can be collected more frequently depending on the measure. Patient level data should be collected in a way that allows the recipient, the subrecipient, and in your case, the subrecipient, to analyze service and outcomes data for health disparities and equity. And I couldn't stress enough the importance of doing so. We see many agencies who are not yet doing that, and you miss things in the data that identify a need for improvement when we are not analyzing data to be able to view health disparities and to address equity. And you could analyze the data in a variety of ways in which to do so, and it really depends on the regions that you serve for what is most appropriate. We have a question. I think it's a question, or is it a statement in the chat box? Client experience data can be used to meet PCN.
It was just a comment.
Oh, just a comment.
I just
okay.
want to reinforce that thought that you shared, or that point that you shared.
Yeah, absolutely.
It comes up a lot in Texas. We have a portfolio of performance measures that are set up in our data system for the state, ARIES. And some of the things like transportation and, food bank are very difficult to
Mhm.
measure. And so using client satisfaction surveys or experience data is very
Yeah.
important for everyone to have heard that. So thank you for talking about it.
Yeah, it is. Those are some of the hardest service categories to set measures for. And so, yeah, I would always recommend experience data for those, because ultimately a client's health outcome could be linked to whether or not they were receiving the experience they needed to receive in order to continue to come back to access the service in order to have better health outcomes in the long run. So experience data is great in that case.
There was a point made in the chat room about a nuance between experience evaluation and satisfaction, and that's well noted. Satisfaction is a type of experience evaluation.
Mhm.
So we want to make sure that we're thinking broadly about experience evaluation. However, in terms of the, kind of fingers on the pulse, surface level, bellwether performance measures, like we probably would be looking at satisfaction data, but that's not to say that other things like, you know, exit interviews, entrance interviews, other types of key informing interviews, focus groups, those other assessments, could also come into play, but probably, for a bellwether CQM performance measure, a survey question is probably, better.
I think that
Great.
answered the question
Well,
in the chat. There we go. I think we're moving to next slide, Michael.
yeah.
There we go. So I'm talking about quality improvement, which was that yin to the yang of performance measurement. As a Part B subrecipient, quality improvement needs to be tied to the overall quality management program as laid out within the quality management plan. And the accompanying work plan. So as mentioned earlier, we want to evaluate our quality management program and its quality improvement activities in each cycle of our plan. Improvement science is a large field and has many applications for the healthcare industries. Recipients and subrecipients are required to utilize an evidence-based approach named within their quality management plan in order to I'm sorry, I lost my way. In order to apply your improvement practices within your state or your region. So as mentioned at the beginning of this session, our focus is on HIV quality outcomes, which will improve through improving patient care and satisfaction within that care. Quality improvement activities are identified based on data. Activities include training, learning collaboratives, quality improvement projects, quality conferences, stakeholder engagement activities designed to collect and disseminate information. Ideally, recipients have written protocols, tools, and instructions for use in training and in guaranteeing subrecipient participation in statewide or citywide QI activities. So examples could include QI reporting forms, instructions on how to use them, and training on both aspects. I saw the question in the chat. What definitions on the performance measure do you use? State, HRSA, or you create your own? Oh,
Yeah, so just in response to that, we should raise this in discussion because I think
yes.
that that's a really important question. We will have a session on performance measurement in 2 months in January. So, we might be able to dive in and scratch the surface today, but then really get deep on this in 2 months when Jasmine is back with us.
For subrecipients, quality improvement activities are aligned with the recipient QI activities, and so it'd be very similar for subrecipients. So they could participate in trainings, join group learning activities, complete QI projects, etc. It's really, you really want to have recipients. And in your case, also a subrecipient at an AA level, really guide the work that's being done within the state, and having your providers or your subrecipients really follow your lead in that work as they set activities for their own agencies. Next slide. So quality assurance versus quality improvement, also a very tough point for people when we're splitting hairs in this work of CQM. So it is essential to note that quality assurance is not the same as quality improvement. Quality assurance, sometimes also called quality control, is about ensuring compliance with minimum standards and focuses on improving deficiencies to meet those minimum standards. As such, quality assurance is administrative. It is not part of your CQM program. This is one of the toughest things to split hairs with for state, city, or provider level programs. Once people get to understanding the difference between quality assurance and meeting that minimum standard that is required for compliance, and then understanding that quality improvement operates separately from that, then you really get to adding the extra layer that we talked about earlier. Next, this slide's going to help talk through that. So quality assurance is contract monitoring as far as a recipient or subrecipient relationship goes. Quality improvement is about moving beyond minimum requirements and really stretching to achieve optimal outcomes. So you see here on the left, quality assurance is, again, measuring that compliance with standards or contract monitoring or chart reviews. Focused on individual bad apples. So what did you as an agency do wrong? What are you as a person doing wrong that's providing this service? It is responsibility of a few to carry out quality assurance. Quality improvement, on the other side, is continuously improving performance beyond that minimum service standard requirement expectation, and focusing on health systems and processes instead of individual bad apples. And it is truly the responsibility of all people when you're seeking to create a sort of a culture of quality.
We can't emphasize this enough. This is another one of the really, really, really key points in terms of our federal expectations and the way that we talk about clinical quality management nationally, is that there had been this sense beforehand that if you had a site visit and there were findings, that is quality improvement to address those findings. But that's actually not quality improvement. According to our, according to the slide that we have here and the way that we think about clinical quality management nationally, a site visit is compliance, that's grant administration. Therefore, findings related to site visits are also grant administration. If you're trying to take something and really knock it out of the park, so let's say that you have a whole bunch of negative findings from chart reviews, and a committee then decides that these negative findings from chart reviews means that we need to chart differently or make an improvement in the way that our system operates, only that piece of it is quality improvement. The chart review itself, not quality improvement. The findings of the chart reviews, not quality improvement. The way that the system responds, not the way that the agency responds or the subrecipient, but the way the system responds is quality improvement. And I think that that's a really important thing to emphasize.
Yeah, and Julie, you're right on track there in the chat. Response to monitoring is corrective action plan. It is not your quality improvement work. Exactly. I think that leads us right into discussion opportunities.
Yeah, so we're about halfway through our presentation, and that was kind of the really bare bones introduction to the Ryan-White HIV/AIDS program, Clinical Quality Management. We rooted ourselves in the policy clarification notice that comes from our federal partners that describe quality activities in the quality program in the Ryan-White HIV/AIDS program. And we also really dove in terms of that ball and pedestal, infrastructure, performance measurement, and QI. and helped you to identify what are the activities that are required from the state's lens, what are the activities that are required from the direct service provider's lens. And we're trying to help you find your way in the middle as administrative agencies to help make the state program a reality for people in the field in your regions as administrative agencies. So we've had some great conversations so far in the chat. I wanted to open it up more broadly to see what folks think about this introduction and these basics. For folks who have been trained before, do you still have questions, or did this add value? And for for folks who have never been trained before, did this help to baseline you, or do you need anything else to help provide a baseline?
We have one person in the chat, Stefan. Missed a brief moment, but would QA and QI both be under the umbrella of QM?
So the industry, our industry, like let's forget about Ryan White, let's forget about healthcare for a minute. There is a concept called TQM, total quality management. Total quality management is quality assurance and quality improvement together. But we don't do total quality management in Ryan White. We do clinical quality management in Ryan White. In clinical quality management, QA and QI are not the same thing. QA is administration, QI is clinical quality management. This is a source of great confusion for us in our field because so many of us who were trained traditionally based on healthcare and industry standards think about TQM, and we have to forget about TQM to make room for CQM, which is the way that we do business in Ryan White.
Christy
Great
says
questions.
this was a good refresher from what she's heard before. Great, I'm glad. Refreshers are so important for us as adults so that points really stick. Good to hear things multiple times.
So I'm not sure if this is coming up in a later session or not, but what's the difference between the quality improvement that you're required to do as the recipient versus the subrecipient? Like if you have a small region as an administrative agency, do all of your subrecipients need to have their individual QM plan, or can they join in your QM plan? And if you're a big region, what would your recommendation be?
So this is actually a clarification that HAB provided to a group of us most recently. And that is that it is up to the recipient to determine the extent to which subrecipients or sub-subrecipients need to have infrastructure in a formal way. So some places have stopped requiring subrecipients to have QM plans. And instead, they say, we just need to have a sense of what is involved in your QM activities. Personally, I do think it's a good idea to have it written out, in terms of having a separate and, kind of fully fledged QM plan. But that, again, is a decision that's up to regions. So in a place like Texas, the state can decide whether or not everyone has a QM plan, or the state can decide that it's up to the administrative agencies, and then the administrative agencies get to decide. But in terms of thinking about, from an infrastructure standpoint, the actual requirement our federal partners have is just that the recipient makes a decision. And then if the decision, is that there's a plan, then there's resources and kind of like, templates available for people to base their own plans on. If there's not a requirement for a plan at the recipient level for subrecipients, then the recipient needs to provide subrecipients with a sense of what is required.
Thank you, Michael. That makes sense. And thank you, Jasmine, for the great presentation so far. Very great.
Thank you. Can you hear me?
Yes, very
My
well.
my screen is glitching.
I can see the disco light in your face.
Yes, so I'm like, what is happening? I'm trying to get on from my phone.
Oh, technology.
I know,
we'll bear
it's
with
so
you.
exciting.
We'll bear with you.
I just need the meeting password, Michael.
just a second. The meeting password is 223049.
49.
Mm-hmm. And I see that Tiffany actually has a question. Should your CQI committee focus on only QI and QM, or would you incorporate QA as well? That is such a great question, because what you're trying to do is you're trying to engage your stakeholders in a conversation about quality. From my perspective, I think that you need to be focused somewhat on QA, because QA is going to give you a sense of what needs you have potentially for system change. So for example, if you have a whole bunch of providers that are not achieving a desired result, maybe it's something about the system that makes that result unachievable. And it's not about the providers themselves being unable to achieve that result. So it depends on how you look at this. And I think that you need to approach it from both angles in a quality committee to be able to pursue this well. I think that the important thing is that we always have to be focused on improvement and not just focused on what the results are showing us, because then we can end up in a place that we know as analysis paralysis, right? Where it's like, there's data. What does it tell us? I don't know. What does it tell us? What does it tell us? That's no place to be in. And I think that that's the hazard that you have when you bring in too much QA into your QM committee. You need to be able to focus on improvement and get beyond the analysis paralysis. Jasmine, Tiffany advised that her screen did the same thing. She exited full screen by hitting escape, and then it worked for her. So
Wow. Well, I got on from my phone and I restarted my laptop, so we'll see if it fixes.
Oh, that's so funny. You're on there twice. Okay.
Yeah. It should say I left. It does. It just says I left.
Okay, cool.
I'm still here.
Thanks everyone for bearing with us. My DVR is like possessed and keeps like opening and closing next to my feet. That's why I keep looking down. So we're all in it today.
Yeah.
Great. So
we're gonna move into some poll questions.
I just wanted to see if there's any. I noticed that a couple folks had unmuted, and I don't know if it's because they wanted to get a word in edgewise or. Yeah, go ahead, Oscar.
Yeah, I just have an observation around that quality work, and we've been having your help and support. It is fabulous, but we need to think about we're changing a culture. Every time at the AA someone read the word quality on the requirement or the report, it just dump back to the CQM program. Whatever quality it is, your main solution has the word quality on it. Every time to drop something about your main solution and quality, they just don't pass the whole bulk of things related to quality in quotation marks, because okay, we're breaking that culture and defining what is QA and what is QI, because for years it's been have been taken as the same thing. And you're changing that culture is taking very intense effort. Just FYI, and thank you very much for your guidance on this, because that helps to change that concept, and not just a concept, but it's a culture. So I just want to make that observation.
I really appreciate that, Oscar, because I think it goes back to that line, right, where we have our authority starting with HRSA and then going to dishes and then coming to you all as AAs and then going to the sub-recipients. I feel like it really is about thinking about how that line works, and about thinking about the system that we're creating that works for people in the field ultimately as the subrecipients. And that's the best thing that we can do, is to think about the guidance that we're providing as administrative agencies for subrecipients in the field to make their lives easier, so that they're able to serve folks. Yeah, I think that that's going to be one of the big and I'm sorry as I'm going back and forth with the waiting room. I think that's going to be an important issue for us to keep asking ourselves as we go through this series. Am I able to take guidance that comes from our federal partners or from dishes, and am I able to take that guidance and to provide something to my folks in the field so that they know what's going on and how to do this? Because culturally speaking, that's something, again, that started at HRSA a long time ago, and it took them a while. DSHS is working on this. We're working on this in administrative agencies, and we're going to work on it with our subs as well. So, you know, this cultural piece is something that's going to, you know, take some time, and we're going to have to be patient with ourselves. Okay. Let me
I
open
think
up.
too,
Yeah, go ahead.
the idea of, you know, really changing the culture things are done or the way things have been done, you do have to be sort of patient with yourself and with all of the levels of work that's occurring within your state, because overnight. And so it does, but it helps to be very consistent then within those changes. So making clear and forward on where do we split hairs and what is my role and what is, oh, I'm breaking up. Somebody says,
Yeah, maybe try turning your camera off and see if that helps, Jasmine.
okay. Can you hear me now?
Yeah, it was just a little
Okay.
bit.
It's a little,
It was just a little jumpy, yeah.
yeah. So really splitting, split those hairs and then standing more firm in that. So what is grant administration management, or what is QA and who's responsible for that versus what is then QI and who was responsible for that. That was something that states and or territories have to do as they begin to make that transition to quality.
Mm-hmm. Simple handouts. Sometimes just asking people, you know, keep the energy going. Hey, what's the difference between QA and QI? You know, whatever works for you culturally also to help with culture shift. We all have nuances, you know, and idiosyncrasies in the way that we act. You know, Texas is one state, but it's one awfully big state. So there might be different ways that you would engage people in your region versus another region in the state. And we can talk about that and ways that you can create these little opportunities as we go. Okay, so let me open these next questions. Jasmine, you want to walk us through?
Question is, I have a clear understanding of the difference between administrative and QM. Question 2 being, what is your in providing CQM specific guidance or technical assistance to provider work? And then the last question being, do you QM leader in your region?
Great. So much of this is really getting at the reason why we're gathering here today, and also seeing if we were able to teach you anything so far. Great. And I see a question came in to me about getting around analysis paralysis. We're going to end up getting into that when we think about the performance measurement piece, Justin, because I think that's going to be something that's really important for that section. Okay, Jasmine, you are now a co-host again.
55% of people who have voted so far. And it's looking larger like people understand the different compliance activities. CQM.
Let's keep these votes coming in. We only have about half of people have submitted for our poll here, and we really want to get a good sense of where you're at with this as learners. So we have 3 questions here for you.
See, got a couple more in.
All right, we'll get one more. Okay. So let me share these results with you.
Having trouble finding the poll, sometimes it hides behind your view of the tiles. So sometimes you just have to play with your view settings to find the questions.
Maybe that helps. Thank you for that, Julie. All right. So we have, most people actually feel as though they have a clear understanding of the difference between administrative compliance activities and CQM. We have folks feeling pretty comfortable and confident around providing CQM guidance or technical assistance.
Yeah.
And we have most people
60%?
feeling, yeah, 60% of people.
Feeling that they are CQM leaders in your regions. That's great.
That's right. Great.
Yay,
Right, well,
we have great leaders in Texas.
Yes.
Well, let's move to the next section of the presentation now, which is really all about being a quality leader. See if we can help some folks with this. Now, a lot of times when we think about leadership, especially in the context of grants management, we think about oversight and management. So there is a little bit of that to pay attention to here. So we will raise that. But basically, CQM is not supposed to be more than 5% of your total amounts under the grants, or over $3 million, the lesser of those two amounts. And so what does this mean? This means that as Ryan White Part B, DSHS needs to make sure that at the state level, that resources going into CQM do not exceed 5% or 3 million. Now, the dollars that come into the field to you, DSHS could end up splitting up that money and giving it to you. And then DSHS aggregates that and makes sure that at the recipient level across all of your administrative agencies, that the amount does not exceed the lesser of 5% of the amounts received under the grant, or $3 million. Something else that's really important to think about is then passing that on to the subrecipients, which is something else that you could do, which then it would be your responsibility at the administrative agency to keep track of those CQM dollars going out to the provider organizations, and you aggregate those, and then you provide them to DSHS and they aggregate those. So, you know, the accountability really does rest with the recipient, even though, you know, we might be passing funds through administrative agencies to the providers in the field. The ultimate responsibility is DSHS, and then DSHS would work with administrative agencies to make sure that, you know, the administrative agency is in compliance. Let's see, a question came in from the chat room. Most agencies are separated by funding. Do you think that causes a lack of understanding in QI and CQM? That's an important question, Carla. I think that we can come back to that in a moment, because, you know, when we think about what it is that the administrative agency does, we don't exist in a vacuum, and we're part of a system that involves other moving pieces too, such as prevention, such as the STI work, tuberculosis, and the other activities that go on. So I think I want to revisit this, Carla. But basically, the idea here is that a lot of times when we think about leadership, we think about funding. There is a funding component, you know, and it's what we see on the slide before us here. But really, leadership is about so much more. Here we have a excerpt of a blog post by Julie Kleiger from 2013. And really, it's talking about 9 essential skills for quality leadership. So 1, setting vision and goals. And by the way, since we're talking about being a leader within your administrative agencies, these 9 skills apply to your administrative agency region. So as an administrative agency, you would help to set the vision and goals for the region that you're a part of. Communicating strategically for commitment. So in other words, the communication that you make to folks in the field, whether they are providers or consumers or other stakeholders, really should be focused on quality in a way that helps to drive their commitment, giving them information that they're requesting, helping them to see how they can be involved, helping everyone to understand the role of their importance. 3, creating an environment that encourages constructive accountability and constructive conflict. So a lot of that has to do with commitment, right? And it also has to do with like how we talk about what our collective vision and goals are. We need to be able to work together to create the environment where we can achieve our vision and goals. We need to be able to work together to be able to identify our opportunities for improvement and then our action steps to achieve those improvements. Accountability isn't about, telling on other people, but it is about making sure that we are all focused and working toward the same goals and the same ends. And if it seems like we're not, to have that opportunity to ask why and, to maybe revisit our vision and goals. We want to remove barriers to success. A lot of times these have to do with administrative issues, but there can be other issues as well. Even in terms of thinking about our comprehension, on this topic and this training today, providing resources like this training, providing templates, providing reading materials and whatnot to help people to be successful is important too. So, sometimes removing barriers is about addressing things like capacity building, and sometimes removing barriers is a little bit more concrete, by actually working with people in the field and asking them what their barriers are. A lot of times we focus on cataloging our barriers and facilitators to see how we can make sure that, we're really allowing people to be all they can be in the field. This next one is really important. And I think that, this is one of the things that sets quality apart from other activities. Other activities, that are related to the grant are about compliance, like you have to do this, full stop. And that creates the sense that we are creating these check boxes for people to go ahead and to check the box. But when we're coaching, we're not telling, we're providing people with curated menus of choices and options that they can select from. And we really want to allow them to be creative and to be innovative in pursuing the thing that works the best for them. So it's really not about telling people. It's not about, creating these boxes for them to check. It's about encouraging them to be creative in exploring their problems and helping them to overcome that. Number 6 is really important, and that is celebrating success and failure. And celebrating success makes a lot of sense. Whenever we have great results, of course, we want to celebrate. But why would we celebrate failure? Well, I think that, it's really important to always acknowledge when people put their effort and their time and their energy into something. And sometimes you can learn more from a catastrophic failure than from a phenomenal success. So it's really important for us to take the moment to appreciate our learnings, whether they're positive, they're negative, or they're null, and to, talk about this in a group format. And one of the best ways to do that is to celebrate our combined efforts, because even if, again, we failed or we had no result, we did something. We came together, we looked at a problem, we came up with solutions, we worked our way through the solutions, and that is a cause for celebration, regardless of the result. Earning trust is something that's essential because it's actually really hard to get people to commit to something if you don't have their trust. One of the best ways to build trust is to help to create this environment that encourages that accountability and conflict, especially when you're listening to people and they see you listening and they see you take their ideas and put them into action. A great way to earn trust is to ask people about their barriers and then to remove those barriers so they can actually see you taking their advice and they can see you listening to them. Working from self-awareness. I think that this is really important in quality to help people to identify, their individualized goals. So the state has goals. You have goals as the administrative agency, but there still is room for all the subrecipients to have their own goals too. So in terms of helping them to see where they're at and how they can get to their ideal state, is a really important aspect of leadership. And then working with and through others is really important. In HIV, we're a passion-based industry, and so we don't have as much of the ego problem that they have in other places. But I still think that it happens sometimes. I'm a person living with HIV for 20 years, so it never ceases to surprise me when people try to claim credit for things that the community has done, or people try to singularly claim credit for something that was a culmination of dozens of people over 10 years. I think the most important thing in terms of being a quality leader is to openly acknowledge the contributions of others and to put yourself second. That as a leader, it's really not about you, it's about the effort you're trying to lead. So why not shine the spotlight and the kudos on those folks, and to work with them, to help them to achieve what it is that they're trying to do, instead of trying to claim credit for yourself, or worse yet, just going it alone and being like, I'll figure this out for everybody else. So I always like to share this, in terms of thinking about what is leadership and what is leadership in quality, because I think that, this blog really succinctly hits on core components. Now, when we think about the policy clarification notice and subrecipients, we just heard Jasmine talk for about an hour about the basic principles of PCN 1502 and what is the nuance between the recipient and the subrecipient level expectations for PCN 1502. And I think that since we just walked through those 9 essential skills, we can kind of put them together. So recipients identify specific CQM program activities for the jurisdiction. We're talking about the state, right? And when we think about the expectations that the state has, when we look at that contract writer that you all have that you put through for your sub-subrecipients, the state has recognized, its largeness and its greatness, and provides a curated menu of choices for you as administrative agencies and for the sub-subrecipients to pursue. So the recipient has provided a theme or sets of themes for the CQM activities, and it really is your role as the administrative agency to bring these to life. So some of these activities include performance measurement, portfolio creation, the frequency of how often, whether or not you collect, disparity segments in your performance measurement data, but also the identification of quality improvement activities, the identification of capacity building activities, and other opportunities for people within your region to bring these state level goals to fruition. Another thing that's important, based on that essential skills is that, you need to make sure that the providers in the field have the capacity to contribute to your regional CQM program, and that the people providing services have the resources to conduct CQM activities in their organization, and the ability to implement a CQM program in their organizations. So what does this mean? Pretty much every single one of these essential skills comes into play when you think about your role as an administrative agency and how you can help to champion quality in the field among your sub-subrecipients. In order to create that opportunity for people to implement a CQM program and to provide those resources, you have to remove barriers, you have to build trust, you have to create an environment where there's constructive accountability and constructive conflict. So I think that these two go hand in hand when we think about our role as administrative agencies and how we help to champion quality in the field. I think, a theme that you've seen in the upper right corner of the slides previously, and that I want to continue to emphasize, is that one way to make sure that we stay out of trouble in this nuance between QI and grant administration is that QI is QI. It's about health outcomes. It's about mortality. It's about viral suppression. It's about retention in care. It's about linkage in care. We can think about all the other clinical quality measures as well that are important, such as cervical cancer screening, such as PCP prophylaxis. There are many, but really what we're focused on is endpoint HIV health outcomes improvement. And we want to avoid monitoring and evaluation, which is compliance. Let's look at this a little bit deeper. So recipients are expected to provide guidance on prioritizing measures and collecting data. Recipients need to work with subrecipients to identify improvement opportunities and monitor quality improvement activities at the subrecipient locations. And we also need to prioritize CQM activities that are coordinated across recipients within jurisdictions. So, again, it emphasizes those 9 essential skills and how we create opportunities for us to learn and grow together based on those essential skills. And, really what we need to do here is to think about how we can focus the activities within our administrative agency regions based on the providers we have available to us. We can't forget the fact that they have other sources of funding, and so we may not be their end-all be-all. We do have direct Part C and D funded agencies. We do have direct Part F funded agencies in our regions. And so we need to be able to think about coordination in that way. Again, as long as we keep our focus on improvement of endpoint HIV health outcomes and we avoid monitoring and evaluation, we'll pretty much be in the clear here in terms of helping us to distinguish what is clinical quality management versus compliance. So again, I want to bring this back here. We're different in a good way in Texas. We have our funder expectations coming from HRSA. We have our regional recipient expectations coming from DSHS in Austin. And then there's a fair amount of latitude that we have as administrative agencies that's provided to us by DSHS in a way that allows us to engage our provider agencies in clinical quality management activities, especially QI activities, in a way that helps to drive endpoint HIV health outcomes. So an important thing to focus on here is a lot of times the effort and the emphasis, the oomph we have for something is based on contracts. So when I had asked for a review of the contract components for CQM, again, this is where I learned that DSHS has a rider that comes to you in the administrative agencies, and you as administrative agencies need to sign off on this contract component for CQM. But there's also the expectation that you slip that rider into your contracts that go to the sub-recipients. So what does the rider include? The rider includes an expectation that there's a QM plan with annual review and update. So there's annual goals, a work plan, stakeholder involvement, including capacity building. So a question was raised earlier. Do we have to have QM plans in the field for our subrecipients? And here the answer is yes. Because we have it contractually obligated coming from DSHS in Austin through us as the administrative agency to the sub-recipient provider in the field, the contract says they have to have a QM plan. Therefore, they have to have a QM plan. And again, that contract also spells out the components that are required. The QM committee needs to meet quarterly, and there need to be recorded minutes that are shared among the stakeholders and participants. So again, this is another question that, I kind of reading between the lines might be something that you're wondering as administrative agencies. Do all of these sub-recipients in the field that I'm managing as administrative agency, do they need to have a QM committee? And according to this contract, the answer is yes. The provider agencies in the field must have QM committees with quarterly meetings, and they have to talk about how they record and share their minutes. All subrecipients have to collect and report the required data in ARIES, and they also have to have a method to validate that data. this is a really important thing that you need to keep track of as administrative agencies in terms of identifying how folks are actually collecting and reporting the required data in areas. Now, this is a relatively new addition to your contract writer, and so this might be something that you're still working out internally. But as you'll see in 2 months, when we revisit the issue of performance measurement, there's a lot of opportunity here. And so it's actually really great that we now have this contract, this requirement included in our contract writer, because it allows us to be able to look at this more in depth as a system at DSHS, within our administrative agencies, and then of course all the way out into the field for our subrecipients. The contract also requires care continuum and other data are stratified to identify disparities. So this is another decision that is out of our hands as administrative agencies. DSHS has made the decision that, that everyone needs to stratify their data to identify disparities. Now, an important thing here is that DSHS did not provide, you know, explicit instructions on what disparities they need to identify or how to, you know, work through this. So I just wanted to emphasize that this is an area where, as administrative agencies, you have the latitude to start working with folks in your administrative agency set to identify what disparities you want to pursue. There might be a point in time that this shifts, and DSHS is providing concrete instructions to you as administrative agencies what to include. I see a question in the chat, so I'm just going to take a moment to read this. So it's another great question about analysis paralysis and how to turn QA into QI. And there actually is a couple of slides that IHI has around this that I think are fabulous. And that will definitely be the way that we talk about this as we work our way into that presentation in 2 months. So I'm going to ask, please be patient because this is such a tall order. It's 8 hours over 4 sessions, and I think that will get to your question in terms of how to help to bring forth clinical significance of QI based on available QA. But yeah, coming back to the slide, the care continuum and other data that are stratified to identify disparities, that is something that you're able to identify as an administrative agency. Or, you know, you can leave this up to your sub-recipients. I think that the challenging thing there is that they do need to have this data stratified to identify disparities. And so if you don't provide the context as administrative agency, you might need to be prepared to provide additional supports to them to help them understand what it is that you mean and how to get from their current state to this ideal state where they are able to track and identify disparities. You need to participate in annual program monitoring. Or I should say they, not you. The sub-recipients need to participate in annual program monitoring. The sub-recipients need to provide updates on program progress to all their stakeholders. So that can be done through the quality committee and through the note share or other mechanisms, but they need to have a mechanism in place to specifically describe their program progress. And then again, going back to the curated menu of choices that DSHS has provided, sub-recipients need to have at least one QI project always ongoing that is linked to one of DSH's 4 strategic domains. So you can see here, the contract writer itself is just one single sheet of paper. It's the front of an 8.5 by 11, but it includes all of this rich detail. And all of this rich detail that helps you as administrative agencies to identify how best to support people in the field around their quality programs. So this is from an IHI white paper called Sustaining QI. I think that this is an incredibly important white paper because it really helps us to think about all the different roles we have within an organization and how we bring quality to life depending on our role. I want to emphasize that this model from the IHI Sustaining QI white paper is actually directed at a large multi-hospital service center model. So you might have, you know, a hospital system with 5 hospitals in 2 counties. It's like that. But when we think about clinical quality management in the Ryan-White HIV/AIDS program, we can still apply this model to our levels of authority, right? So if tier 3 is the executive office or the vice president, you know, that would be DSHS level. And the department manager or director would be your level as administrative agencies. And the providers would take care of direct service provision on the front line and also on managing that front line. So let's take a moment to see, based on this model, how we work as an AA. So interdepartmental coordination is a key task. Obtaining and deploying resources is a key task. Defining department metrics is a key task. And monitor department operations and planning. Remember, the word department here might as well be replaced by administrative agency. So when we think about interdepartmental coordination, that means, what does your administrative agency do with other administrative agencies? And how does your administrative agency work with other administrative agencies to achieve DSHS goals and objectives? Obtaining and deploying resources. How do you, as an administrative agency, work with DSHS to identify key trainings, templates, other resources, and then provide those trainings, resources, templates to the subrecipients providing services in the field? The department metrics, well, that's easy. Those are just the performance measures that DSHS are going to require you to provide to capture anyway. So we don't really need to define these department metrics too much, unless there's something that's very specific to our region and as an administrative agency that is outside of the scope of the measures that are selected by Texas DSHS. Monitor department operations and planning. So this really is pretty much thinking about the standard work that you have as an administrative agency and how your standard work as an administrative agency plays up to the statewide DSHS program and also facilitates the work that's happening in the field at the frontline level. So here are some suggestions for data to control your activities. So in other words, your standard work. So how do you make sure that the standard work, your existence as an administrative agency, is leading to high quality outcomes in the field? Well, you should probably have a sense of how your standard work is working. Are all of the people that are funded as subrecipients in the field, those provider organizations, are they performing? Are there delays in their providing services? Are there delays in hiring staff? These operational issues are key to quality. Thinking about how we can standardize the sharing of data is another thing that's really important for your level as an administrative agency. This is so key for your role as an administrative agency. Coaching the providers on their standard work, coaching the providers on quality and how they can bring quality to life in their organizations in a way that lends itself to your program as an administrative agency region, which then aggregate up to the state level activities. Monitoring the capability of the staff to be able to deliver. So thinking about the assessments that we have, organizational assessments is going to be something that we hear a lot of about through this series. You know, that is going to be one of the main ways that we can monitor folks that are happening, monitor the activities that are happening at the provider agencies. Thinking about our key tasks. As a region, we can do root cause analysis for what is you know, a barrier or impeding our funded providers to providing high quality services to our consumers. We can work as a region to create our own committee or our own plan. Now, I know that for the Part A's that's required, but for those of you that aren't Part A's, it might be something that you consider. That might be the rallying force you need to bring all of your folks together in your region, in the South Texas region or in the Panhandle region. Leading interdepartmental projects. So thinking about, your administrative agency and how your administrative agency works with other administrative agencies. This isn't something that we've focused too much on yet, but I anticipate we'll be focusing on a lot as we dive into USEHE and as we dive into Achieving Together. I'm not going to keep reading through every single one of these, but you get the picture. This slide really helps you to see what specifically and concretely you can do as an administrative agency to help play upward into the statewide program and help to support downward the providers in the field that are on the front line serving our clients. The last thing that I really want to focus on here is to think about how you can work through coaching, conversations, assessment, and how you can help people at the provider level to focus their goals. How do you help them to identify their goals? And then, of course, we want to launch and prioritize our own projects at the administrative agency level. Now, for the Part A's, that's easy because they're a Part A region, and so they're already required to do this. But for the administrative agency level, this is something that South Texas and the Panhandle might consider. Creating an opportunity, through that plan regionally and that committee regionally to create a regional QI project for everyone to focus on. I think that this white paper is a really great read, and it is included. I forgot to mention this before, my apologies, but in follow-up to today's session, you'll each be receiving an electronic toolkit. The electronic toolkit will include this white paper. It'll include the PCN that we've been discussing. It'll include these slides, and it'll include a number of other resources, including that blog post with those 9 essential skills. All right. So, administrative agencies' perspectives. You all, as administrative agencies, are responsible for a regional CQM plan that is tied to the statewide plan and evaluating your regional plan. Regional quality committees and an internal CQM committee and an external CQM committee are recommended, though most folks typically focus on the external committee. In the next session in December, we're going to be really diving in deeply about what we mean in terms of these committees and how they operate. But in terms of, just kind of to give you a sense, as administrative agencies, you have a number of key staff that help to oversee the grant and help to bring the grant to life in the field. And so while there's a nuance, as we've seen and emphasized heavily so far in this presentation, there's a nuance between compliance activities and quality improvement activities. We do want to make sure that the left hand knows what the right hand is doing, right? So we need to have these internal committees potentially as a way to bring everyone within our administrative agency together to focus on quality for an hour a month or an hour a quarter. The external committee is the traditional way of thinking about having multiple stakeholders participate. So it would be some of our own staff, some of our subrecipient providers from the field, maybe some consumers as well, and other community folks who we believe are really important to the work that's happening, whether they're Ryan-White funded or not. Administrative agencies are also responsible for a regional CQM performance measures that are aligned with the DSHS measures. And they're also responsible for regional QI projects that are aligned with the DSHS QI project framework. So again, we can see, coming back to this sustaining QI white paper, we can see that the perspectives that are laid out in the DSHS rider that come to you and go to the subrecipients really do line up pretty neatly with this tier 2 department manager or director level role in this white paper document. So I hinted at this, but there are other administrative agency activities that you have too. besides just helping to monitor the Ryan White Part B activities that are occurring through your administrative agency. And this includes working on Achieving Together, working on US EHE planning and implementation, and other initiatives. Some of us are fast track cities. Some of us are planning on signing up for the National Learning Collaborative that CQII is putting together. There's other campaigns that we participate in sometimes too. And so it's really important to think about, Ryan White is key to the work. Ryan White is the main HIV treatment program in the United States, but treatment is just one side of the coin. When we think about EHE, we have other pillars, right? We also have diagnose, we have prevent, and we have respond, in addition to treat. So we need to think about how all these things, interlock and weave together. One of the things that's really frustrating for folks in the field who are busy serving clients is when we have all of these big clunky initiatives kind of coming in with somewhat aligned and somewhat contradictory requirements and activities. We do need to think about how these things fit together. And we need to ask questions and seek guidance when it's not clear to us how these things can fit together. So to summarize some of the components for administrative agency leadership. HIV is a passion-based industry more than even general healthcare, as I already emphasized. So you have opportunities to help providers to achieve their goals because they're involved in HIV to begin with because they're passionate about it. So you have the opportunity to really get in there and to fire up their passions, to rub elbows with them to help them achieve their goals. Achieving Together, US EHE, and other initiative goals, really allow us to help think about this in a multifactorial way. So if we're trying to get someone in the field to do something, we can say, hello, hospital, you should be doing this new activity because it helps people. That is a statement that can be made, but you're much stronger if you say, hello, hospital, you should be doing this new activity because it'll help your clients and it'll help you achieve your expected participation in these other activities. So you're really helping them to see how one thing is actually checking off 3 boxes. Alignment and programming that works for folks locally. So it's the idea here that, while we might be able to look to Austin for some guidance, it really is up to us as administrative agencies to work with our own stakeholders in the field to establish that trust, to get that dialogue going, to get their unfiltered expectations and their needs from us so that we can really create something that works for them. Helping providers to do the right thing is an important aspect here too. I think a lot of the questions that we've had so far really is on helping us to cleanly emphasize what is expected and how to get around some of the sources of confusion. So you already are aware that, folks want to do this and they want to do it well. So helping us to do the best that we can by identifying specific capacity building that will work in a just-in-time way. So not providing all the training just because you can provide all the training, but what specific training is needed right now to help us to achieve our regional goals. Common QI project reporting and communication tools also help people to do the right thing. And it allows people to feel this sense of simpatico. Because if I have an experience as a provider organization, I want to feel like I'm not just alone, out in space with this, that, there are other folks that have similar challenges, and how can we come together as a group to solve these common challenges? That really helps people feel awesome about the work that we're doing together in quality and gets them excited to come back for more. We have common standards for quality using the validated organizational assessment tool. Again, you've heard me emphasize this a little bit, but we're going to emphasize this a great deal as we work our way through our series here, and especially in the 4th session in February around capacity building. The organizational assessment tool really will be one of your most important go-tos in terms of identifying a common language for quality, a common set of expectations, and a common roadmap for program enhancement. As a person living with HIV, I think one of the most important things too that you can do as an administrative agency is to identify opportunities for stakeholders of all types to participate in our learning and discussions. So of course this includes consumers, but you know, beyond consumers, thinking about immigrant communities, trans communities, the faith-based community, you know, folks that are really, you know, focused on housing, folks that are really focused on food, folks, you know, that are really focused on all these different issues that touch on our patients' lives. So mechanisms for consumer involvement are important, but mechanisms for broader community involvement are also really important. So this has been a lot of information that we have thrown at you, and I want to just step back a moment and see if we have any questions or concerns. I stopped sharing the slides so that we can turn on cameras and really see each other and engage with each other. So I see from Maribel, hi Mary, a suggestion, prioritize a QI project, suggestions on prioritizing with subrecipients receiving various funding streams. So that is a really great question, Maribel. And I think that a lot of this has to do with trying to focus on, you know, how many birds can we hit with one stone? You know, we want to make sure that we're lifting, you know, together. So my sense for this is to point back to statewide regional activities like Achieving Together and USEHE as our, you know, kind of first level opportunity for alignment, you know, and that really should be, because that should be our super aligner, right? Because EHE is an aligning principle nationally. And so anything that comes through EHE or Achieving Together, hopefully would be able to take the face of whatever funding stream is asking for the QI project. But I don't know, Julie and Jasmine, if there's other suggestions that you have for this beyond just kind of looking for lowest common denominators.
Go ahead, Julie.
I was just going to say, no, I think recommending Achieving Together is what I would recommend as well. I mean, that's our #1 focus right now. And there's lots of things you can do to contribute to the Achieving Together plan. And so all of us are involved in the care side, right? So our things are viral suppression, making sure people are getting prescribed medications, making sure people are supported so they can be maintained or retained in care, but also not overwhelming them, because some people only need to be seen once a year, right? We don't need to be hounding them all the time. And then just supporting them to stay virally suppressed if they already are. And growing as a person, right? Some people, they get out of the Ryan White program, they get jobs and insurance and things like that, but they're still in our care systems, right? Not limiting ourselves to just Ryan White, but working with the prevention team and surveillance, right? That's where our people with insurance will be found, looking at our numbers, looking at our data, working together, collaborating, just all the things. This has been so wonderful, Jasmine and Michael, so far. So I'm so impressed, but I would love to hear from you guys and have you turn on your cameras for those of you that can. So come on, guys, bring out some questions. And Jasmine, whatever you were gonna add, please feel free.
No, I think you and Michael really hit the nail on the head. And then, you know, you both have the in-depth understanding of all of Texas's initiatives. And so I think that you all covered it really well.
Maribel, is there anything specific around the types of QI projects that are in conflict? Because I think, you know, one of the things I cut a corner and listening to Julie describe, you know, the discovery process. We have performance measurement data. So how we look at the performance measurement data in discovery to identify where these lowest common denominators may lie. That's one thing that I think is an important thing to consider as well. You know, we have all of this data. Let's look at the data first.
And then if your region is going to join the Create Equity Collaborative, right, you're going to have all kinds of support and a coach and that kind of thing. So as a region, you can start with that, and that will be your 1QI project. And if all of your subrecipients are involved, then they're also meeting our funders requirement, but we'll also be doing some rich work that's going to touch our whole community, not just the people in Ryan White, because most of our clients are most of the people in the community see the same providers as our Ryan White clients, and we treat them the same. So we'll be hopefully touching the whole state, right? If we can improve systems of care.
Hi, this is Rhonda. Andrew, can you guys hear me okay?
Hi, Rhonda.
Hi. I just wanted to point out that we I really want to emphasize how the process of looking at our monitoring, the assurance aspect, and using that as our baseline, but not our key things that we're going to focus on. Those are just the baselines of, how we're working from year to year. But then also we have started doing a coaching sessions with each of our providers because of how unique they are and how they service different clientele, and they have different things that they're working on, other programs that they're leveraging. And so that allows us to really hone in on what they want to focus on and make those the best efforts, and not so much, okay, so the whole group is focusing on this, so then they have yet another project they have to focus on. And so we've really tried to, this year is our first year to implement the coaching sessions, and that's more building a relationship and how important it is that we're building a relationship with each of those agencies so that they can continue their own relationships with the clients. But also that monitoring, it's been so important to understand the data, and that if the data is not good data, as we are focusing on each individual agency, they can realize how important that data is too. So we've been even training them on how to do some of the care continuums, how to run their own report. If they want to focus on a specific quality improvement measure, they can do that with the data. But if they're seeing data is a little skewed, we can help them improve that, but we won't know until they run the reports themselves. So we just wanted to commend Michael. You've been a huge implementation, or a huge just an important factor in all of these changes, because we had one of your sessions a year and a half ago, and that was kind of one of those stepping stones that we needed to hear that stuff, and just continuing to receive this information and this guidance, even though we feel like we're at a really good point. This helps us to realize that we're on the right track, and it's just really good to see these things being shared with everyone else in the jurisdictions. So I commend you, Michael, and thank you, Julie, for having us on this call. But just wanted to share with you guys that important information. Thank you.
Thanks, Rhonda.
Yeah, that's great, Rhonda. Like, so the coaching that you all doing in Indiana, we called them TA visits, or technical assistance visits, and we were doing very similar work, and that was identified as really gold star work in the way that you operate with your subrecipients by HRSA. So I commend that work that you're doing. I encourage you to continue to do it and to continue to grow those relationships, and really give each of your subrecipients or subrecipients everything that they need in order to be supported within the work, because they're all so different, and oftentimes serving very different communities, and which means that there's different needs for improvement that has to occur. So that is very not only practical and a great use of resources, but really gold star work to do.
I see Brian has his hand up.
I just from the perspective of, I don't know how the AA staff feel, but I thought that when you all talked about quality improvement and quality assurance from the perspective of the contracts for the AAs, I thought that was good. So that if I was thinking, like on my end, if I was hearing that, so that would kind of clarify things, at least help give me kind of a map to make sure that as a self-check that I knew that I was taking care of things. So I thought that was interesting and good and helpful, I thought.
Thank you. So one thing that Rhonda had mentioned, I think that we're going to focus on, we'll emphasize it a couple times in other sessions, but by the time we get to session 4, that organizational assessment really is the basis, I think a wonderful basis by which we can create that coaching. And Jasmine had pointed that out as well. By the time we get to that session also, we'll be able to show you how you can crosswalk these types of technical assistance and coaching conversations into something that would make other parts of the administrative agency very happy, such as looking at the monitoring and evaluation aspect of quality, but keeping it clean and keeping it so that the work that you do for quality is focused on coaching and improvement, and letting the other part of the administrative agency handle that compliance piece of it. So it is all about teamwork, making the dream work.
Thank you for mentioning that, Rhonda. I can share an example. So Rhonda Stewart, our contractors that do our monitoring for quality assurance, has worked in the background to contract Michael to provide us this quality improvement education, right? Or quality management education. So that's kind of one way of separating it in your mind. But it's all it's all connected, but yes, very separate. And I think that's where we get lost a lot of the time, including myself, right? I think I sent Stephen, who asked about is QA and QI under the umbrellas of QM. I told him that, but now I learned that that's total quality management, right? Not necessarily the HRSA version of clinical quality management. So always learning, lifelong learning is a great thing. And I highly recommend it. And I'm so glad you're all here learning with me today. So bring on the questions or comments, guys.
Hello, everybody. It's Sonia. I have a question for you all. And definitely very good. We love Michael and Jasmine. It's nice to meet you as well. And glad to hear some of your experiences in Indiana. My question is about the coaching sessions. And can you talk a little bit about any successes you've had with involving clinical staff in the coaching side of it? I know oftentimes we hear they're so busy and their schedules are full, and so they can't always participate, but how you get them on board. If you could talk a little bit about that.
I have a whole bunch of ideas myself, but Jasmine's been so involved in doing this with providers of all shapes and sizes across her state. So Jasmine, do you want to take a stab?
Yeah, so my computer glitched for a second, but essentially you were asking about how to involve clinical providers within coaching sessions.
Yeah.
Yeah.
Yes, and how successful it's been, whether or not you've gotten their buy-in to participate.
Yeah, so it really does vary by the type of provider agency that you're discussing. So I've done work from executive director level or clinical director down to direct service providing staff working with TA. A lot of times where I would see clinical staff is when we would do direct technical assistance with a quality committee. At our general technical assistance visits, unless the program we were operating with was a hospital setting, we didn't typically have the providers present in the room, again, because of things like the scheduling of the providers. But in a hospital setting, should you have any subrecipients who are operating within that setting, we would have their like chief medical officer or their lead physician on their HAB team within those meetings. And it would depend, right? So sometimes they would want to focus on only very clinical or QA sort of side of things. And we'd have to help steer them in the direction of QI, sometimes catch them up to pace with some of the work the organization was already doing, some of the trainings maybe other staff at the organization had already had. But they would in general, generally get on board and see the opportunities and the way that they fed into the work for improvement. Julie asked about, oh wait, I think there was one more. How long I've been doing, okay, Michael answered that. Julie asked about, do I feel showing the clinical leaders data helps get their buy-in? Yes and no. So it kind of depends on the data that you're showing them. If the data that you have directly matches with the data that they think they have, then yes, showing them data does help get buy-in. If your data does not directly match the data that they believe that their agency has, then you sometimes run into like these tips of, well, that's not what we think our data looks like, and having issues there. Michael, did you start the poll?
I did. Sorry, I should have
Oh,
said.
no, you're fine. You're
Yeah.
fine. You're and so it really would vary on the agency. And so part of doing that technical assistance or these coaching sessions is really getting to know who are you working with and building those relationships. I was just telling somebody last week that was the most important part of the work that I was doing, because in building those relationships, then you understand, how do I communicate with you? What do you need from me in order to help drive you towards our common goals? And how can I best support you? And so that is like an essential part of doing that work. And you really you began to figure out the ins and outs, along with what are the general things that we're just going to provide everyone as blanket technical assistance. Right?
The thing that I would add to that is basically, if you've been part of your service system for a while, you have a sense of what drives different agencies or individuals within agencies, you know, so you can create that boys club feel by saying, hey, I'm coming to meet with your staff. This is what we're going to be doing. I want to call you for a half hour after the session to download the results to you. And for some people, they're like, yes, that's exactly the level of involvement that I want to need. You know, but it's basically just kind of helping people to understand whether it's an entrance interview. Hi, we just want to start out the day, and if your clinical leader could be here for that part, that'd be great. You know, that I found a lot of success doing it that way, because then you know, that first domain has to do with leadership, and then, you know, after that it has less to do with leadership, and you can get them as needed. But really asking them and kind of getting their perspective of what level of involvement they want or need to be able to drive their staff's, you know, activities, you know, I think is the most important way. Okay, so where are we at with our poll?
Oh, well, let me see. I closed my.
So we do have a poll live right now. We have 23 out of 36 of you who have voted. And I think that we can end the poll because there is an evaluation as well. Jasmine, you want to walk us through the results while I pull up my slides?
Absolutely. So it looks like about 74% of you agree that you feel confident in advising Ryan White HIV/AIDS program provider organizations in your region on CQM expectations, or you feel more confident than you did at the beginning of the webinar, which is great. And with another 17% of you strongly agreeing. So that's wonderful. It looks like we got most people pushed in the right direction. You feel more like a quality leader in your region, more than at the beginning of this webinar. And the majority of you would agree with that as well. And so that's great that we have pushed you forward in that direction. And hopefully over the next couple of months, you'll continue to feel more confident within that work.
Great. So just real quick to show you that we have a bunch of resources available for you. We will be providing, again, via email following this session, the toolkit that has a lot of goodies, including the PDF version of these slides. So you'll be able to click through these resources on your own. And then we have 3 more sessions that are coming up. A session in December on regional CQM committees and QM plans, so basically looking at infrastructure. A session in January that is focused on performance measured data and activities. And then a session in February that'll be focused on capacity building and evaluation. That'll be heavily emphasizing the organizational assessment that we've been discussing today. So I just want to round out real fast by inviting you to complete our evaluation, which is our last poll for the day. And I really want to thank you all for joining this conversation. It was an exciting and full 2 hours filled with general information, but then also focusing in specifically on how you can exercise your role as leaders for quality in your regions. I really appreciate you're taking the time to complete these evaluation questions, because we're going to be debriefing with the Dishes and Germain Solutions team tomorrow to identify some highlights from today, and also to think about the next 3 sessions that we have. While each of the sessions are designed to be 2 hours, we wanted to ask these specific questions because we can make tweaks to our programming depending on your needs. It is all about you, after all. This is to help with your learning and to help drive your participation. So we really appreciate you taking the time.
Looks like we have 66% of the poll in.
I don't know, Julie or Janina or Rhonda, if there's anything else that you'd like to say in closing for today.
I actually just want to say another thing that I found was really important is it's okay to make mistakes. It's okay if one of your indicators just didn't quite turn out, and one of your goals, and you have a PDSA and everything, it just didn't turn out the way you thought it would, but that's okay. You learn from those, whether you're going to tweak it and do it again, do something different with the same service category, or you're just gonna say, no, that's not what we're ready for. So yeah, that's all I had to say.
Thanks, Rhonda.
This is Julie. Just wanted to say, great presentation, Jasmine and Michael. Thank you so much. I learned some new things today, and I look forward to the upcoming sessions. And I welcome anyone else that has any comments or last thoughts.
Hey, you all, good afternoon already. Thank you so much for joining us. Thank you, Michael. Thank you, Jasmine and Julie. And I want to just echo you all's thoughts about, this is a process, right? And this is a process that usually takes a lot of years in order to get to a point where we could start seeing some substantial outcomes, even though we've been, in this space for a couple of years. We have seen some very good increases in viral suppression, but this, like anything else, there's mistakes made, then you pivot and you take a different action. And so I just want to congratulate you for all the work that you're doing out there, and that this is just the beginning, and we have a long way to go, but I'm very excited about that. Thank you all.
Thanks, everyone. And thanks, Janina. Have a wonderful day, and we'll see you in 2 weeks. Not 2 weeks, 4 weeks. Bye.
Bye.